Hi, my name is Dr. Schlang. I'm the Chief Dental Officer of Smile America Partners. And the purpose of this video is to help you give the children that we treat a calm and comfortable dental experience, while at the same time allowing you to have a calm and comfortable experience while treating the children. I've been with the company for 10 years, and half of what I do is administrative, and the other half is I'm out in the field as you are, and I'm providing dentistry to the children, and I try to be out in the field as much as I can because the kids are a lot of fun. And also, when I'm out in the field, I tend to demonstrate visits to dentists who are new with the company. A number of the dental assistants have asked me to make this video because they find that some of the techniques that I use to calm a child and to get a child to be, let's say, happy or almost happy to have dentistry done, they feel that it's something that I should share with all of you who are treating the children. So when I come to a school and I set up for a visit, I'm trying to make the setting as fun as I possibly can. So usually what I'll do is I'll put Pandora on my iPad and play either 60s, 70s, 80s, 90s music, or a combination of that. Sometimes Motown, sometimes there's a Pandora station called Kids Pop that I play. And if possible, I try to keep the room that we're providing care in as fun as possible. So I don't ask the children to just sit down, fold their hands, and behave. I like the kids to walk around, interact with each other, come over and watch me if they want, and in general, not feel that they are in a classroom where they need to sit still, be quiet, and pay attention. It's sort of like the opposite. The other thing that I do is I travel around the country doing this, so I'm usually working with a different chairside assistant each visit. And I talked in my conversation before seeing the children my conversation with the chairside assistant, I explained that if a child exhibits any type of anxiety, that I prefer that the chairside assistant leave the talking to me, because any word that is interpreted by the child as getting them to feel too anxious to have treatment can cause it to be impossible for me to continue with trying to make the child comfortable and have treatment. If the child is gregarious and likes to talk, I have no problem at all with my dental assistant having any type of conversation whatsoever with the child. I also ask my assistant, while I'm working on the child, to not be controlling in the sense of telling the child what they should do in terms of behavior. For instance, if I'm going to ask a child to breathe through their nose, I'm not going to do it as a command. I'm not going to say, breathe through your nose. What I would usually say is, gosh, my mirror's getting all fogged up. You must be breathing through your mouth. You can really help me have my mirror not fogged up if you breathe through your nose. Can you do that? And that's how I'll get a child to breathe through their nose. If I want the child to tilt their head back, I just don't say, tilt your head back. I'll usually say something like, gee, my neck's been bothering me and I have to really turn my neck around to try to look into your mouth. But if you tilt your head back, it's going to make it a lot easier on me, and my neck won't bother me. So I try to, instead of giving a command to the child, I try to tell the child that if they do this, they'll be helping me. And I find that that works a lot better. And I ask my dental assistants, don't say something like put your hands to your side and stuff like that. Try not to give orders. Many of my dental assistants are mothers, and they're used to their children doing what they tell them to do. But in this situation, we're trying to get the child to be as least anxious as possible. That doesn't necessarily work out. In the visit, we have a lot going for us that's advantageous over a traditional dental office setting. One of the things that we have going for us is that the children are in a comfortable environment. They're in their school. Usually we set up in a classroom. So they're at ease that they're not in a dental office. The other thing is that they're with their friends. In general, we have 3 or 4 kids in the room at the same time. Some kids are playing and some kids are receiving treatment. So if it's sort of like a play situation and kids are receiving treatment, and the kids who are receiving treatment don't seem to be bothered by what's going on, and they're having a good experience, it's the children who are waiting naturally become less anxious, because what we're doing, the treatment we're providing, is in complete view of them. We don't set up screens or anything to make it so that something mysterious is going on behind the screen, where it's the ultimate open bay. So being in a familiar environment, having your friends nearby, trying to set up the visit to be friendly by playing music or letting the kids play, that is really a big positive that really helps us out a lot. The thing that we don't have that most dental offices use is that we're not using anxiety relieving medication. We're not using, certainly not using any kind of restraint. And we're not using nitrous oxide, which is a really safe and effective way of calming children and helping prior to giving local anesthetic. Another advantage that we have is that we're using electric handpieces. And over the last 10 years, myself and other dentists in the program have developed techniques of using electric handpieces at a slower setting. And because they don't make the whine of a high-speed handpiece, because they don't have the power of or we don't set it at the power of a air turbine high-speed handpiece, we find that we can relatively painlessly do approximately half of our restorations without giving local anesthetic. So those are the advantages. I went over the disadvantages. One of the big advantages we have is that we have consent, and the parent is not present in the treatment area while we are performing our procedures. A number of pediatric dentists and dentists who have parents in the treatment areas very often comment that the parent, although the parent wants to be helpful, the child could read any type of anxiety on the parent's face, and that translates to the child. So in general, we've got it good in that we're without the parent. But of course, we have school administrators walking in through our visit, school teachers walking in through our visit, and we certainly are only working on the children with them being volunteers, and we are trying to provide them with the least amount of discomfort possible. So in order to provide the child with the least amount of discomfort possible, I find that the more relaxed the child is, the better my chances are that that child will have a comfortable experience. And I start the process of having the child be relaxed at the instant I meet the child. Prior to the child coming over to my treatment station, I usually look at the chart, look at the x-rays, check the box that has the medical alerts, check the birth date so I know how old the child is, make sure the 2 identifiers were taken care of so that I'm working on the right child. And then I look at the x-rays and I will call to my assistant on what I observe. If there are restorations that I see that are needed radiographically, I'll let my assistant know. Then I call over the child. And when I meet the child, what I say to the child is, "Hi, my name's Elliot, what's yours?" I find that's a really nice way to introduce myself to a child. It sort of takes down the barrier of I am a dental professional and the child is my patient. I'm trying to establish a friendly relationship with the child. So it's, "Hi, I'm Elliot, what's your name?" Then I ask the child to lay on the treatment table, put their head in the headrest, and the first thing that I usually do is I pick up the air-water syringe, and I'll say something like, "Hey, do you know what his name is?" And usually they say no, and I'll go, "His name is Mr. Wind," and I start spraying air on their neck, their nose, their face, and it usually evokes a smile from the child. And I do that with the saliva ejector, and I also do it with the handpiece. And one of my favorite movies is Toy Story, where each of the toys has become personified, and it's a great movie and it's a lot of fun. And so if I see a child's distracted and I don't have the child's attention, I can take Mr. Wind and spray it on the child's cheek, and the child will look at me, and I say, "Don't look at me, it was Mr. Wind who did that." So the air-water syringe becomes personified. I show them what Mrs. Thirsty does, because it's Mr. Wind, so it becomes Mrs. Thirsty. And I also show them my handpiece, and I say, "This is my tooth tickler." And then I proceed with the examination. And I look in the child's mouth, always wearing my loupes. I dry the teeth, have good lighting, and call out the teeth that are present, call out the existing restorations, and then call out the additional caries that I identify with the oral examination, check the bite, soft tissue. And then after I've done that, my assistant knows to automatically write the child's treatment plan on a Post-it. And while my assistant is writing the treatment plan on the Post-it, what I'll usually do is ask the child to sit up, and I'll grab the flowable composite syringe. And my favorite flowable composite is Accolade SRO Extra Light, because it is the color of paper. And what I'll do is I'll take their hand and I'll put a dot of the Extra Light composite on each of their fingernails, take a curing light, and I'll cure that, and I'll ask them to feel their fingernail, to feel the set-up composite. And I'll explain to them that what I'm going to be doing is taking the sugar bugs out of the teeth and replacing it with this filling material that comes out liquid and it turns hard. The thing that I'm accomplishing with that is that I'm showing them that the flowable syringe is not a needle. It's not an injection. And I find that's very important, because I could be in the middle of treatment and I pick up the flowable syringe, and then the child starts moving around, takes off the Talfamire that I may have on the tooth, and gets upset because they think that I'm going to be giving them a shot. So I get that out of the way, and it's another nice way of breaking the ice between Mr. Wind, Mrs. Thirsty, having the dots on the fingernails, having that set up. And then I'll ask the child to lay back down. My assistant will hand me my treatment plan on the Post-it. And by this time, I've also thought out, am I going to use anesthetic? Am I not going to use local anesthetic? And in what sequence do I want to do this? If I have a 5-year-old, in general, I'm going to do as much of the work that I can without using local anesthetic, because regardless of the management technique that I use to give local anesthesia, the child will usually wind up not cooperating. And I'll go into that a little later after I explain how I give local anesthetic. If I have a child who's almost 7 and up, in general, I'll try to use local anesthetic and do it in such a way that it's really an actually painless experience. So let's say I'm going on the upper teeth, I usually infiltrate with lidocaine, and in children on lower teeth, I usually infiltrate with articaine, septicaine. And the reason for the articaine septicaine is penetrates mandibular bone very well, at least for deciduous molars. I haven't had that greater success with septicaine penetrating for let's say the first or second permanent molar through infiltration. So I will say something like Lido to the dental assistant that I've talked to before, and I'll explain that what Lido means if I say it is hand me some topical and then get a syringe with a 30 gauge short needle ready with a carpule of lidocaine. And once I say Lido, she'll hand me some topical lidocaine, which I'll be applying. But before I apply it, I say to the child, smell this and tell me if it doesn't smell like bazooka bubblegum. And then the child will say, yep, that smells like bazooka bubblegum. And then I'll get into, I'll put the lidocaine on, and it's not the lidocaine, the benzocaine, the topical anesthetic, on. Usually I'll inject just superior in the deepest part of the vestibule of the deciduous, upper deciduous molars. And once I've applied it, I'll say to the child, yep, it smells like bazooka bubble gum, but if you chew gum, you need to chew sugar-free gum, because gum with sugar causes cavities. So then I'll say sugar-free, and the child will say sugar-free. So I said, that's the kind of gum you should chew. Tell me again, what kind? And they say sugar-free. And that's a helpful distraction to the child, and it's teaching the child something. And then a lot of times before I'll start, I'll hold my 2 fingers up in front of the child's face, and I'll wave my 2 fingers, and I'll say, how many times a day are you supposed to brush your teeth? And usually they'll get the clue from the 2 fingers and say, 2. And I'll say, exactly, brush your teeth twice a day, morning and before you go to bed. And then I'll say, for how long should you brush your teeth? And I'll say, and I'll give you a clue. It's not 2 seconds. And I'll say, each time you brush your teeth, how long should you do it? And usually they figure it out and they say 2 minutes. And I'll say, that's right. If you don't brush long enough, you're not going to get your teeth clean, and you're not going to protect yourself from getting cavities. What kind of gum? Sugar-free. By this time, I feel that I usually have a nice rapport with the child, and I've helped the child with their oral hygiene. So the dental assistant knows to hand me the syringe underneath the headrest, and I'll tell the child, tilt your head back and close your eyes, and don't peek. I would say over 90% of the time, after I've done what I told you, I get complete cooperation with that. They tilt their head back, I retract their cheek, try to make the deepest part of the vestibule taut. Naturally, I have my loops and my headlamp on. I don't want to do anything without that. And I, as best as I can, I penetrate the mucosa maybe 1/8 of an inch and simultaneously gently press my thumb on the plunger, and then I stop. And then I count to 10 to myself, and then I press a little bit more. And while I'm doing it, I'll say, don't forget, no peeking, no peeking. And usually that works out perfectly. Now, let's say I have a child who, let's say it's a 10-year-old, and they have what's called an 8-pack. A is an MO, B is a DO, I is a DO, J is an MO, K is an MO, L is a DO, S is a DO, T is an MO. So I'll give them, let's say, a half a carpule for the upper right, half a carpule for the upper left, and then I'll go and use Septicane on the lower. Same technique. The only difference is that whereas I can get it to be virtually painless for the upper, usually they wind up feeling a tiny bit on the lower. But if I can make the upper injections pain-free, usually the child will give me a pass on the lower. The other thing, back up to my initial injection, the other thing that I tell my assistants, and which they learn in dental assisting school, is that, yes, I know that when I go to give an injection, you're going to want to put your arm over the child's arms. But I say, please don't do that. And the reason why I don't want them to do that, because if the child is peeking, once that arm goes over, they become alarmed, and that ruins it. So that's basically my technique and how I calm the child, try to make it fun, and give the local anesthetic. Now, before I do procedures, if the child's very calm, I usually don't go back with the anesthetic. But if the child is nervous, I find that it takes more anesthetic than usual, because they have a heightened sense of pain if they're very, very anxious. But at least I know that from injecting in the vestibule, that I've got relatively good anesthetic. If I feel that I'm going to need more, then what I'll do, and I'm also being conscious of 1 carpule of anesthetic to 20 pounds of body weight, what I'll do is inject into the buckles of the interdental papilla. And that is pretty effective. And also, you only use a very slight amount of anesthetic. And that's basically, I'm set to go with that. If I feel that I want the anesthetic that I don't want to spend the 5 to 10 minutes waiting for the anesthetic to take effect, I'll ask the child to sit out while I see another child who perhaps needs anesthesia, and then I'll get the first child to come back after I've anesthetized for the second child. Then I don't think I have anything to add to what I just told you about that part of it, but then there's the situations where I'm not going to be using local anesthetic, and I want to go over how I get the child to be a volunteer for that technique and cooperate through that technique. So the instances where I usually won't use local anesthetic is if I have occlusal decay in the pits, grooves and fissures, or buccal pit or distal lingual groove, and it's not deep. Usually what I find is, and it's, let's say, first permanent molars, usually I find that with a 330 burr, I can paint my way into the tooth without causing discomfort, and then using advantageous bonding situations to make sure that that filling is retentive. But before I attempt to do that, I'll tell the child, I'm going to remove some sugar bugs. It shouldn't bother you, but if it feels like something, it probably is going to feel like cold water. But if it feels like more than cold water, raise your left hand, and that means stop to me. If it feels like cold water and it's not bothering you, leave your hand down, and that means go to me. So after I do that, I don't just start with the handpiece or my tooth tickler, as the child knows it. What I do is I start rehearsing the raising and the lowering of the hand, kind of like a Simon Says thing. So I'll say something like, feels like more than cold water. If they don't raise their hand immediately, I'll say, too slow. You got to be able to stop me when you want me to stop. And I'm trying to reinforce the idea that they're in control. So then I'll say, okay, let's go. And if their hand goes down too slowly, I'll go, come on, we got to get this fast so that you really got it. And I'll go, stop. And if they raise their hand quickly, I go, yeah, you got it. And I'll keep repeating that. So I spend a minute or so to try to make it fun before I begin. And then I begin. So let's say I'm trying to get decay out of the grooves of a permanent molar. What I'm doing is I'm not going vertical with my 330 burr. I'm using brush strokes with a lot of water, and I'm going horizontally. And of course, good lighting, loops. I'll be saying good lighting, loops, and all, over and over, because I find that so important. But I'm also keeping the child's hand in the corner of my eye. If I see the child's left hand begin to move, I'm going to move somewhere else on the tooth. Or if I'm preparing multiple teeth, I'll move to another tooth. So this works very well for shallow preparations in grooves, pits, and fissures. And in order to get retention, the way that I handle this is very much like a sealant. I'll use concentrated etch, dry the tooth, use concentrated etch for 20 seconds, flush it off, make sure that I have my frosting, put my bonding agent on, cure that, and then I know that very much like a porcelain veneer bonding to enamel, my composite is going to bond perfectly to basically the prep that I have that let's say is 80% enamel. And the kid can chew on all the Jolly Ranchers the kid wants to, and it's not going to pull the restoration that I put in out. There are a number of instances where I'll use the same technique of no anesthetic, and that's with deep decay. And let me try to explain how I do that and why I do it that way. And it's all of what I'm telling you that are, let's say, guidelines and the things that I find, the work in the vast majority of the time. But there are instances where I won't use local anesthetic, and then I'll say, gee, maybe I should have. Or where I use it, I go, you know what, I really didn't need to in that situation. But let's say I have a 5-year-old, and the 5-year-old has deep decay and a lower deciduous molar. And I know that if I attempted to give local anesthetic, that I could very much risk having that child, let's say, fall apart, and not literally, but emotionally, and I've missed an opportunity to treat that child. So I'll rehearse the raising and the lowering of the hand, and then I try to use the deep decay to my advantage. I'll try to use the deep decay as an insulator from stimulation to the nerve of the tooth. So I paint my way in, and I'm looking to make an outline form. And in my outline form, what I'm looking for is 2 millimeters of clean vertical wall and 1.5 millimeters of clean gingival floor if it's an interproximal class 2. Once I've achieved that, I stop with the handpiece. And usually I can do that without the child's hand going up, because the deep decay, which is sitting over the pulp, doesn't transmit stimulation very effectively. So then I stop with the handpiece, and then I use a spoon excavator, spoon out the infected dentin, the soft decay, leave the hard, and then put a indirect cap over that, usually with something like limelight, resin-modified calcium hydroxide, put a band on that and fill the tooth. And if the decay is very deep, usually I'll take the tooth out of occlusion. And that brings up another thing: how do children without local anesthetic tolerate pedo bands on Toffelmeyers? And surprisingly, if, once again, you're wearing loupes and good lighting and you place it slowly and gently and then tighten it, usually works out fine. And before I do that, I show them the band and the Toffelmeyer, and I say, this is my tooth hugger. And I said, you know, the filling material is soft. I have to hold it in place before we put the light on it to make it hard. And I'm going to put the tooth hugger on. You might feel a little bit of pressure. Usually works out great. So those are the techniques that I use in managing a child prior to treatment. I find that if we can get x-rays of a child, in other words, if the child cooperates for x-rays, 95% of the time I can provide that child with treatment. It brings up something that we just recently instituted, in that when we put ourselves out for comprehensive care, the parent, the school, the dental community, and the regulators, and the dental insurer are expecting us to accomplish the dentistry that would be accomplished by the average general dentistry office. In other words, they don't expect us to take x-rays, do an exam, and refer out things that a general dentistry office would say, oh, that's no problem, and takes care of it. So we should only be referring out children who have extensive decay, are totally unmanageable, and require a pediatric dentist, or children who we really feel that they have special needs and they'd only be safe in a, let's say, in a hospital environment, being put to sleep for their dental treatment, or in a pediatric office. Not children who could be treated successfully in a general dentistry office. So all of our classifications of the children that we see are 2As unless we strongly feel that that child can only be successfully treated in by a pediatric dentist. The unfortunate thing is that when we have children who are candidates for pediatric dentists, it's still very difficult, because we're a safety net program. It's difficult to get our children to be taken to fixed dental offices. So alternatives, if a child is too young to cooperate to receive dental treatment and they have open caries, an alternative would be, if the child allows you to excavate with a spoon excavator, dry off the tooth, obtain some isolation, and flow in some resin-modified glass ionomer. We have IonoSeal. Cure that, and buy yourself some time so that perhaps when we come back to the school, let's say we come back 6 months later, that the child may have changed emotionally and is more apt to allow treatment. Other techniques that I use with children is I'll have them observe me providing treatment to a child, and as long as that treatment goes well, and sometimes I'll have them I'll tell them, I'd like you to assist me. They'll be my assistant. I'll put a mask on them and have them observe a couple of children. And then I'll ask them, are you ready for me to provide treatment to you? If they say yes, that's great. If they say no, I'll say, I'll tell you what, why don't you go back to class And if it's in the morning that happens, often I'll have that child called in the afternoon to come down, and then I'll say, "Are you ready now?" Sometimes I get a yes. But anyway, having the child observe dentistry being performed, explaining what's going on, very, very often that gets them to decide that, hey, you know what, this isn't so bad, and I do want to cooperate. And a lot of times, if you let them observe and then they go back to class without treatment, and they see their classmates come back with their little goodie bags and their toothbrush and their sticker, by the afternoon, they change their mind. So what the message here is, don't give up. If you've done your best to be fun, to show the child that you're a fun dentist, and the child has confidence in you, or try to get the child to have the most confidence in you that they can. In other words, to feel like not only is this dentist fun, but I know this dentist knows what they're doing. And that doesn't work to provide treatment. Try the other things, like having the child be an observing assistant, or having a child go back to class and calling the child later. Anyway, that about concludes it, and I hope that the techniques that I've described and explained has come in handy to you to get your children to have a calm and comfortable dental experience, while you yourself have a calm and comfortable experience while providing treatment to the children. Thank you very much.